Mhm. Okay, good afternoon, everyone. So welcome to today's referral for FES, webinar for FES and referrals. So we're going to be talking about what FES is, clinical guidelines, and how to refer to us within the BSW area. So first question, and this is where I'd like you to shout out, is what do you know about FES and what do you understand about it?
Well, I had a few patients that I ended up referring to. Sorry, you can probably hear my daughters shouting, just calling me. So yeah, I had a few patients that I referred over to Ostok Medical for FES, and they actually managed quite well when we think about their symptoms before they started using it and how it was after. So like I had a patient with quite bad foot drop, but after he started using FES, he was able to take his dog out on a walk, on fields, literally everywhere. So yeah, he was doing pretty well.
That sounds really, really
Mm.
positive.
Mm.
So you've seen it as a really good positive treatment to help. Actually, that's a massive improvement on quality of life.
Oh yeah. He was great anyway with his exercises. Anything you would ask him to do, he would just do it.
Yeah.
So I think he was doing pretty well.
Good. Kate or Daniel, what do you know about FES?
Obviously I've seen the foot drop stimulators and know a little bit about electrode placement and things for hand and wrist stimulation. Our stroke patients quite often have the ones for the hand, and then the stroke and MS patients can get the ones for the foot for the foot drop. I don't know a huge amount about the settings and the kind of the intricacies of setting up the different frequencies, and the modes kind of make sense for the way some of them ramp up and then down again, or go on and off, or stay on permanently depending on what you're doing. So yeah, they kind of make sense. Yeah, I think most of the ones that I've seen have come from you guys.
Okay, good. Okay, and do you have anything else to add, Kate?
Yeah, I work in private practice. I'm a private physio. I work in the Salisbury area, so and got quite a few patients with the foot drop stimulator, and also the upper limb microstim device. And I've got a microstim device as well that I use in my practice as well. So yeah, really good results. Similar to Paulina, I have a patient who also walks his dog over the fields with maybe the I don't know. But he does amazingly well with it as well, and really can't be without it, and it's just become part of his routine really. So it's great. But I just really want to tie up the referral kind of criteria, just to see if I can refer or to have to go through the GP. I just want to be absolutely clear, really. That's why I take.
Brilliant. Okay, so basically what I can gather, you all know about electrical stimulation, what it can do, how it can change your life, and how it fits into practice, which is really good, but we'll go over that. So just to recap, what is it? So we've got electrical stimulation. We use surface electrodes on the whole. I think there are still some Salisbury patients with implanted electrodes, but for the purpose of what we do it for, we use surface electrodes. And what we're doing is we're getting a muscle contraction by mimicking an action potential. So it gives that electrical stim to get that muscle moving. The difference between, say, a neuromuscular electrical stimulation and functional. So in neuromuscular, the timings are set on the device. So with the microstim, you'll know that it ramps up, it stays on for a certain time in an envelope, and then comes off. And but with the functional electrical stimulation, it's triggered. So we have a foot switch. So when that foot switch comes off the ground, it triggers, the stimulation comes on, and then it comes off when the heel goes down. So we trigger it generally to heel rise. However, if someone can't get the heel to the floor, we might need to put it on the other shoe. So it will trigger on heel strike, not heel rise, or we stick it under the first metatarsal. But that's down to patients themselves and what works for them. So we've got a couple of videos here, and these are two service users. And just take a quick look at them. So in both the videos, they start without the stimulation on and then with it on, and they've actually both got quite similar associated reactions, which you will be able to see as well. So here you can see very short steps, step 2 gait, that foot's inverting, it's not clearing the floor. Now she's got it on, and very clearly you can see she's got a very a longer stride length, she's got a reciprocal gait pattern, and that foot drop is corrected. And you can see how much more confidently she is walking. On to the second video. So here you can see a lot of tone pulling that foot in as she steps forward. Again, step 2 pattern, small, short steps, and using a walking aid. She still requires a walking aid once on, but you can just then see how clearly the foot drop is corrected. She still has a step 2 gait pattern, but that clearance is much better, and you're not fearing that she's going to fall. So in terms of clinical guidelines, there are several. I've highlighted them here, but the ACPIN FES guidelines were released in 2022. Then the RCP stroke guidelines were released in 2023. We've got the old guideline for FES for foot drop, which is from NICE in 2009. Then we've also got MS guidelines, which refer to the 2009 NICE guidelines. We've got the 2022 guidelines after traumatic injury, and the NICE guidelines for cerebral palsy in adults. What I have missed off, because it's come out so recently, is the new guidelines for chronic neurological conditions, including ABI, which again have electrical stimulation quoted all the way through it for use in rehabilitation and for walking. What is noted in all of these is that patients should be able to manage FES, whether either with a carer or independently. They should be offered it depending on the patient's needs and local provision, and it's there for upper and lower limb. Yep, what we'll know and I'll go through is that the funding is generally for lower limb only. We often will have to do other things to get upper limb funding. So in your area, it is funded: Bath, North East Somerset, Swindon and Wiltshire. Your patients are generally be seen locally in Salisbury, at Oddstock's home in Glanville. And what we will also do is that you can refer to us, and they will come in, get triaged, they'll get set up once they've had approval from the GP. So we can assess for upper limb, but we would need to do what's called an independent funding request. And if we were using, again, for lower limb, but not for foot drop, we might also need to complete an IFR, unless they were, say, using a 2-channel, so it's foot drop plus hamstrings, for example. The criteria for this is that it's skin surface electrodes, so the ones that go on your skin, and that they've got a foot drop due to upper motor neuron damage, that they're not able to use a foot orthosis, or why an ankle foot orthosis might not be appropriate. So often they wanted you to have tried something else. And what I'd say, the benefit of the FES over an orthotic is the FES is active, so the whole foot moves through range. And one of the things that comes out in the research is not just the foot drop and reduction of falls, but actually there's an increase in push off because the foot's having to move through, compared to an AFO where you don't get that push off because your foot's just held in a passive position. So when they say can physically manage an FES, plus or minus minimal assistance. So for example, if they were hemiplegic, often people can set it up on their own still, but they would be allowed a carer, or if it's a child, for example, a parent needs to help them. So that's not a contraindication here. The fact that we need to have clear treatment goals and expectations of benefits. So one of the things we do to help show this is complete outcome measures at each appointment. And one thing that because we have to apply for continued funding, generally through clinic letters, that if there is no significant improvement or there are safety concerns, then we would discontinue it at that point. So if it's no longer being clinically effective, then it wouldn't be continued. Sometimes actually with stroke, however, it's because actually the patient's improved. So after year 1, they have annual reviews. So we need to keep seeing them each year. We tend to like to do this face-to-face because at this point we will repeat all their outcome measures. And actually we get a nice long-term picture of how it affects that patient, how it affects their quality of life. We use numerical rating scales as well as timed walks. So if a patient is deteriorating year after year and they're no longer able to walk, that's probably when we'd also be looking at discontinuing treatment. And that's often a joint decision between ourselves and the patient. So moving on to referrals, as I said, we can accept a referral from any health professional. So Kate, you said you work privately, you would be able to refer to us. We would then, that's why we need the GP details, because then we contact the GP and say, yes, do you agree to this? And they would then, we'd be able to go forward with treatment. So things that we like to see, so being specific about the diagnosis, whether it's MS, stroke, the date if you have it, and their affected side, including the use of AFOs and other orthotics, if they've been trialled in the past, is really useful for us when we start writing our clinic letters, because we're trying to justify that funding. But they can use walking aids. So just because they need a walking aid doesn't exclude them from treatment. At the end of the day, they can use crutches, frames, etc. False history, we do ask this during our assessments, but if you've got anything that you can tell us, that helps us as well, because it's nicer to have as full a history as possible when we go into the appointment. And any recent clinic letters, so anything that from a consultant or from discharge summaries, that would be relevant to help us when we're going into that initial assessment, is always useful. So other useful information, so some of you said you've got devices. So if you've got a device within a service and you've done a course and you're confident using it and you've trialled it, actually, when you send us the referral, you can put this in. You can put in what parameters you used, how long it's been trialled for, and actually what effects it had. Because if it had a good effect, that kind of helps us when we go to assess. And it also helps us if the patient already knows what it's going to feel like as well. So because then they know what to expect from the device as well. Medications, not essential, but can be helpful. Not all patients remember to bring the medication list with them, and they're looking it up and can't remember how to pronounce them. So if you can include medication list, it does help us. So when we get the referral, what happens is it gets triaged by our senior clinicians. The ICB criteria is checked. So for BSW, for a lower limb patient, it can go straight to initial assessment with setup 1. Once the GP gives their approval. If we need to do an independent funding request, say for it's an upper limb, then we would book them an initial assessment free of charge. They'd come in, we'd assess, then we fill out all the relevant paperwork. And this is probably when the clinic letters come in really useful, because we can use that as evidence when we send off those RFRs. So waiting times, because that's always what patients want to know. How long will I have to wait for treatment once we've done the referral? So it's about 6 to 8 weeks for initial assessment. And this is whether a GP approval is required or not. And then after that, all the future appointments occur. So they're expected to see us 5 times in the first year. So it's quite a lot in the first year, but that helps with getting used to the device, any things that might need to be changed or altered during that time. And even with those appointments, if they have any problems, they've always got an open door policy. They can always contact us if there are problems. So if running in place, that's fine. They have their appointments. If we need to apply for funding, it can be 2 months or more between initial assessment and setup, and that's because we have to fill in the independent funding request form. It gets sent off to the ICB. They might want further information. The panel might not meet that regularly, so it can be a bit of a waiting game. But we try and be as efficient as possible with that. And as said, it's about 2 months or more. Probably better to advise your patients longer than shorter, so they know to set their expectations and manage them. So what happens when they come to us? So we will look at both walking with and without stimulation. Obviously, we need to know how they walk. We always do a Borg RPE. So we give them a nice little table. They'll tell us how effortful it is, and we look at their fear of falling as well, particularly if they are falling regularly. Sometimes they don't fall, but they trip a lot. So that's another thing we'll always ask. Even if they don't fall, how often do you trip? Because they often trip quite a lot. The reason we have 2 sets of appointments is so they can get used to the device. So when we come back in, that tends to be a week later, we can set goals with them. And then these are reviewed at 6 weeks and 18 weeks. So, and if they get any further goals, we can also set these at this point. These goals are then reviewed and get put in, because we use a goal attainment scale, they get a score, and we can put this into their later clinic letters to show how well or how much of a difference FES has made to their quality of life. So when we're looking at their clinic letters, it will show the referrer or the GP what the outcome of the assessment is, and any outcome measures we've done. So, as I previously said, we have up to 5 face-to-face appointments in the first year. At any point during their treatment, they have signed a loan agreement form with us, and that they sign at the initial assessment, which is commitment to appointment attendance, but it also is it gives them their device. So that device is on loan for that entire time, and it continues to be on loan for as long as they're in treatment. The reason we have so many appointments is to give that support to the patient, so we can get the best set up so they can feel supported. And then after that first year, depending on the need for appointments, we'll either see them annually or every 6 months. And this can be reviewed on a yearly basis. So if we get to a certain point and they're becoming a bit more complex or things have changed, then we might put in a 6-month review, and we just apply for that through clinic letter to the ICB. So to summarise, FES is funded in the BSW area. It is an evidence-based treatment, and it's in many clinical guidelines, and it's becoming more and more in the clinical guidelines quoted and researched. The more information you can give us on the referral form, the more it helps us. And if you can include notes or clinic letters along with the referral, particularly if they've been assessed with FES, it helps us going forwards. On the next slide, I've got a QR code which has the referral form, so feel free to get it downloaded onto you.
Ellie,
yes.
Sorry, there's a newer version.
Is that was the latest one I put on? Though it
Is
says V3, it is the V4.
V5.
There's a V5. I'll make sure the correct link is emailed out to everyone. Because I didn't realise there was a V5. The last one I heard was a V4. So apologies for that one. That's fine. This is why I have Bryony here. So yeah, I will get the correct link emailed out to you all after this is finished. The next slide is about questions. So I'm going to come off sharing so I can see you all, and feel free, anything in the chat or any questions you'd like to ask, please just go away with them.
And do you get the funding improved for upper limb? Just thinking, because I think we had a patient that we referred over, that was a few months ago. We started chasing that like 2 months after his initial appointment. But then we were told that the funding request is only just sent once we started chasing it. So the patient waited quite a few months to hear that he's actually not going to get it.
I can only apologise for that one because I don't actually work in Salisbury, so I wouldn't know about that. But we do try and get the funding requests off as soon as possible. It could be that they were just snowed under with paperwork or awaiting different clinic letters and things. So yeah, we do have a team that work on funding and getting that available. Unfortunately, when we look at doing independent funding requests, we have to show clinical exceptionality. So it's great that it's in the clinical guidelines and it's there and it's supported as an evidence-based treatment, but that almost takes away that exceptionality because everyone should be getting it. And ICBs are really trying to cut down on how much funding they're giving. There are alternatives. If a patient doesn't get funding, they can go down the pathway of being a private patient. But we do what we can. We try all we can to get funding in place first. Beautiful cat there, Kate.
He's gotten fed. Okay.
Yeah. I hope that helps.
Yeah, just thinking because we have quite a few patients now that are using microstim, which we lent them and then we borrowed from the other teams as well so they could use it. But then we were just thinking, are they actually going to get one? Just thinking about the chances of getting one.
Yeah.
But yeah, well, let's hope they will. We'll see.
In terms of microstim, it's because before I joined Odstock, I worked in the NHS and I had patients that had purchased them. And if they purchase a microstim, they are advised that they are set up by a clinician. So if they wanted to purchase a device, they'd become a customer with this strong advice that they are set up by a trained clinician. Generally, that means having done the upper limb course. So there is that option as well. And I'm sure Abby can chip in here.
Yeah, sorry to just pop in so late into the meeting. So there's been a lot of work done around upper limb. It came into the guidelines that patients should get more routine funding for more routine treatment and that it should be something they can take and use at home. In the guidelines, they put in about the extended time that they should be using it and the frequency that they should be using it. There's been a lot of work with the ICBs because they are seriously underfunding treatment, and we do have to do these IFRs at the moment, which means I think last year we got about 5 through in the year. So that just tells you how many people we can apply for and won't get funding. Anything that we can put into a funding application that would show that a patient is different. So when Ellie talks about exceptionality, different to the rest of the patients that have the problem. So they will be looking for anything that sets that patient apart, either in the presentation of their problem or in the benefit that they're going to receive. That doesn't mean they'll get funding. It just means that they are different to the rest of the patients, and that's what exceptionality is. There is no definition as to what exceptionality is, so it's really just proving everything that we can. We recently went through a consultation with some other ICBs, 6 ICBs, so Kent and Medway, Hampshire, Surrey Heartland, Sussex, about upper limb. We put a massive case forward to them along with colleagues from Birmingham and Queen Square, And the result of that was, unfortunately, we won't be funding upper limb FES because we can see that there's pain relief and other things to it. There's no cost saving to it as there is with lower limb FES. So lower limb FES can be justified because of falls and hospital stays and people being housebound, whereas upper limb, we couldn't prove really that there was anything very standout or that would say that could be used instead of something else. So instead of an AFO or instead of a hospital stay or any of those things. So for those reasons, they came back and said that they wouldn't be looking at funding routinely upper limb, and we would need to continue to submit the IFRs. So I don't think realistically anytime soon upper limb will become a routinely funded service that OML can offer. It will be something that has to stay in the rehab departments, which we appreciate can sometimes be really short term for stroke patients or any other patients that need it. Another point to that is that upper limb FES, we know it needs to be delivered quickly after the patient is ready for their treatment, and that waiting that very long period of time while we're doing IFRs and everything else to be declined is unfortunate, but our hands are tied with the ICBs. They're just not budging at the moment with upper limb because they're so restricted with the funds they have available for treatments they've already committed to.
Yeah. That said, it does leave a gap in the research for cost saving, because there probably is a cost saving when it regards to splinting, when it regards to pain relief. For example, if you follow Nick Ward in the upper limb programme at Queen Square, he said if you prescribed FES or NMES for shoulder pain versus pain relief, there would be a cost saving, and it's better because it's not a pharmacological treatment. But showing that to an ICB in terms of numbers would be really, really difficult. And I think that's where there's research gaps, which hopefully will start to get filled in the future when you get clinicians at universities wanting to do this. So yeah, it's an ongoing battle. It's great that it's against us that it's made it into clinical guidelines, because it's saying it should be there as a treatment, but then it's proving that exceptionality, the difference when basically they're saying every patient, if they don't come under the contraindication, should have access to the treatment.
I think the other thing is that we're quite fortunate we're in an area that funds lower limb like regularly. I mean, for instance, with Sussex, they don't fund. Dorset don't fund at all. So I think the fact that we are in an area and in a position to be able to provide the treatment for lower limb, I know it's unfortunate with upper limb, but we've got something that we can provide, and then we can do the IFRs for the upper limb, and we've got the ability to provide that treatment if they want to be able to go private patient. And with our private patient costs, they're not unreasonable. They're not through the roof. I mean, it could be for some people depending on their financial situation, but it's nowhere near as expensive as lower limb. And I think that's quite a difference.
Yeah.
So can I just ask, for upper limb, would you mainly be looking at pain relief for the shoulder subluxation and alignment kind of issues, rather than say forearm, wrist, hand for spasticity management?
No, it depends on the patient. So I'm not a BSW patient because I tend to see patients more Norfolk way, etc. So East Anglia. And I had a patient with MS who doesn't have functional use in her right upper limb. And I managed to get an IFR through. And since she's doing that, so we've been working on hand shaping, wrist extension, and then also elbow flexion extension. And she's had some massive functional gains. So to the point where she can actually start to use her right hand as a stabilizer again, which is pretty amazing. And that's within about the space of 3 months.
Yeah.
So the changes are happening quite quickly. And as soon as, even in the initial assessment, as soon as we stuck it on, her spasticity just went down. It really decreased. So
great motivator for people, when they can actually see the movement. And then, I think it really, it's another adjunct.
Yeah.
But I think it's a real great motivator that I can see, but it's good to get cleared up on the referral criteria. That's great. Thank you.
Yeah.
I think the thing is that getting people in for an initial assessment, getting a referral in and getting them in for initial assessment, even if they don't get the funding, the fact that they've been able to feel it, and because we get people that are really unsure, they don't really understand it. So the fact that they can come in, see what it's like, and then actually if they do end up needing to pay privately, they're more inclined to, because they're not just thinking, oh, actually, I don't know what this is, so I'm not going to pay the money, which is totally understandable. But the fact that they get a free initial assessment, they find out all the information that they wouldn't necessarily found online, they have that ability, and they come in and they see someone face to face, and I think that gives people more confidence in the process and in the treatment. So then when, if it does, the unfortunate situation is that they end up having to pay, they're more inclined to.
So you do that initial assessment before that you put the IFR in, is that right?
Yes.
Yeah.
And the initial assessment's free of charge.
Right. So if I was to refer somebody, you would get them in, do an assessment, do the referral.
We do the IFR, yeah, from the initial assessment, yeah.
I think it would be fair for the clinician, and I think our clinicians would do it, to meet the patient's expectation by saying, I don't think this will be successful, because patients need to understand that just because we're submitting it doesn't mean that we're going to get it. So if the patient has a very normal presentation for their condition and their benefits are going to be very normal as to what you would expect, likely chance is that they're not going to get funding. So we need to manage that expectation early on.
Yeah.
Which, from the patient support side, when we do the bookings, it is something that we highlight while we're booking them in for the initial assessment. It's not that they're going in blind. They do understand that we need to apply for funding, and it is very difficult to get funding. So we do give the private patient cost even from the initial assessment before that, so that they go in knowing all the information.
Yeah, that's for upper limb. Obviously, if they're a lower limb,
it's different.
then it's fine. We just ask the GP for approval and we can go straight ahead with treatment. So that's fine.
Great.
Okay. So yeah, as I said, I'll make sure that I'm going to email. So when I stop the recording, it will save. I'll email it out to everyone, and it will include the latest referral form, which I'll double check I've got. Okay. Any more questions? No? All right. I will let you get on with your days then, unless you got a question, Daniel.
No, I just thought, well, I'll say thank you for the presentation. I didn't have anything else to ask.
Okay, good. All right.
The only thing I just want to add in terms of the referral form, we do have a safeguarding information. So if they can't work with a woman, female, male, it's quite important information. So if we can get that detail, if you do have it, if it's not a worry, then don't worry. But that is a key question for us in clinic.
Yeah, as well as lone working. So potential for lone working. Okay. All right.
Thanks, Ellie.
All right. Thank you, everyone.
Bye.
All right.
Thank you. Bye.
Bye.